we've got this initial information, we've got a diagnosis, we've got some initial feeling about prognosis. Let's talk at least briefly about sort of how we treat thyroid cancer. Naifa, let's do this in two parts. Let me ask you about treating sort of the low and intermediate risk patients, and then I'll come to maybe Frank and say, tell me about treating these really high-risk patients. How might they differ or be the same? So the typical lowish risk patient that we see that's going to do well.
Yes, so first we have to know how to define the lowish intermediate risk patient. And so, things that we talked about is the imaging preoperatively as well as intraoperatively, but it comes down to the postoperative pathology TNM staging. And in thyroid cancer, we have the typical TNM tumor nodal metastasis staging that we have in other cancers, except we have age that comes in as a factor for differentiated thyroid cancer. And so when we look at that, we look at the age and then the size of the tumor and the nodal status, whether it's central or lateral neck disease, as well as whether or not they have distant metastases. And the lower intermediate risk would be somebody who just has a tumor. Just has no lymph nodes, but just has a T on the TNM and is an N0 patient. Those are fairly easy to deal with because okay, this is a patient who is low to intermediate risk with maybe the exception of the T3, T4 patients that are older. And the patients who have M1 or distant metastasis are the high-risk patients. So in that sense, it's easy to define the low versus high risk, but then everything else is intermediate, and the question is, what do you do with that? So I always talk to my patients that it's a three-pronged treatment in thyroid cancer. Surgery is the first and best chance at cure. And whether it depends on different philosophies, whether you do a lobectomy or total thyroidectomy at the outset, and the subject of many debates around the country. But let's say one has decided to do a total thyroidectomy, whether or not lymph nodes are removed prophylactically. So if no lymph nodes are identified on preoperative imaging, then there is no specific standard that says you must remove lymph nodes for differentiated thyroid cancer. Depends on what surgeon you talk to and what you believe. And then, but if lymph nodes are identified on preoperative imaging, then those lymph nodes should be removed in a proper manner, in a proper lymph node dissection, and not just plucking or removing the lymph nodes that are abnormal. And the reason I make a big deal about that is we see lots of patients that come to us and say, my thyroid cancer keeps coming back year after year after year. When is it going to stop? And the question is, did this disease ever disappear? You've probably always just had multiple surgeries of what we call plucking. And so the surgery is the best chance at cure. Getting it right done up front with a thyroid cancer surgeon, I think, is the best chance at cure and will do well for the majority of our patients. The second step is radioactive iodine after surgery. And with the new guidelines and more research that has been coming out, there's been a more critical look at whether or not radioactive iodine is really necessary and is really helping patients. So looking at those patients that we would consider from their staging and their risk factors, if they're considered low risk, surgery is probably all they needed, and they probably did not need that adjuvant therapy with radioactive iodine. Whereas the patient who's high risk, who is probably going to recur, radioactive iodine may be necessary in those patients. The intermediate patients are a little bit harder, and the guidelines are how many pages?
Too many.
Yeah. So the guidelines are very, very, very long, and it's easy to tell if the low-risk patients should be treated with should skip radioactive iodine. But those intermediate patients are those who have, maybe the younger patient who has T3 disease, or with a little bit of extrathyroidal extension, or the patient who had central lymph nodes. Maybe those are patients you could skip radioactive iodine, and you have a pro and con discussion with the patient whether or not you want to give it. Those who are elderly with lateral disease, that becomes you're going to at least take a look and decide if you want radioactive iodine. But again, with good surgery and smaller lymph nodes, that even those patients, we may be able to skip radioactive iodine. So I think those intermediate patients are a lot harder in terms of what we're going to do. And I think with more research and more, looking long-term at these patients, how they do, we may actually have a better defined group of who we skip radioactive iodine in. And then the third treatment, so after you've done surgery, yes or no, maybe radioactive iodine, the third treatment is to give them thyroid hormone back because they no longer have a thyroid. And giving them a little more thyroid hormone than their body needs, or TSH suppression, is the anti-cancer therapy. And so with that explanation, a lot of the patients are happy and know that 85 to 90% of the time, you're going to do fine just from this beginning treatment if we do this right, and not over-treating you, because our goal should be first do no harm.
Yeah. So we've clearly moved away from a one-size-fits-all. Frankly, it was easy to treat thyroid cancer
I
then.
know.
Everybody
it
got
was.
surgery, everybody got radioactive iodine, everybody got a TSH of 0. I had nothing to do. All the selective use is really difficult. Where do you really keep the TSH? When I trained back last century, we kept everybody's TSH at 0 forever. What do you really do in Texas now? TSH of what?
Texas.
In Texas.
So TSH, for the low-risk patient, the younger female with small volume disease, the stage 1 patient, we're actually keeping their TSH between 0.5 and 2. And the higher risk patient who we're more worried about will keep their TSH between 0.1 and 0.5. And then the highest risk patient will keep their TSH not undetectable, because there's been some research to suggest that we can actually harm them and increase atrial fibrillation and fractures and harm their bone health. But maybe like between less than 0.1, but not all the way down to 0.01.
So it's very few that we keep their TSH 0 anymore, right?
Yeah.
I mean, we've really moderated on that.